Hello, my name is Alejandro García. We're going to discuss an interesting topic, and this is granulomatosis with polyangiitis, gastrointestinal complications. Granulomatosis with polyangiitis is a systemic vasculitis, ANCA associated. ANCA means anti-neutrophil cytoplasmic antibody, also named Wegener's granulomatosis. It's a small vasculitis according to the Chapel Hill classification, and is also known by its necrotizing reaction with few or no immune deposits. GBA forms ANCA-associated vasculitis with microscopic polyangiitis and eosinophilic granulomatosis with polyangiitis, also called Churg-Strauss.
Hi, my name is Dr. Les Mertz, and I'm a rheumatologist at the Mayo Clinic in Arizona. I would like to tell you about an autoimmune disorder called ANCA-positive vasculitis and a new study that the Mayo Clinic is participating in at this time. Most of you already know something about the immune system. When the immune system functions normally, it helps to fight off viruses, bacteria, and cancer cells. When the immune system functions abnormally, you may develop unusual infections, or damage to the normal cells and tissues of your body. Autoimmune disorders develop in such circumstances, and you already likely know about some of them, including rheumatoid arthritis, systemic lupus erythematosus, dermatomyositis, scleroderma, and vasculitis. One of the most common types of vasculitis is ANCA-positive vasculitis. ANCA stands for anti-neutrophil cytoplasmic antibody and represents the antibody that can be found in your blood when you have one of these conditions. There are actually three of these, including granulomatosis with polyangiitis, previously called Wegener's granulomatosis, microscopic polyangiitis, and eosinophilic granulomatosis and polyangiitis, previously called Churg-Strauss granulomatosis. If you have granulomatosis with polyangiitis or microscopic polyangiitis, your doctor will likely prescribe medications that suppress the immune system to reduce the inflammatory damage that may occur to your tissues and organs. These medications may suppress the immune system enough that you will actually develop an infection or be at increased risk of developing a cancer. In April of 2001, the FDA approved a new treatment for granulomatosis with polyangiitis and microscopic polyangiitis. Since it is a relatively new treatment, the pharmaceutical company is sponsoring a study to help determine even further the benefits and side effects of this new treatment being used for treating patients with ANCA-positive vasculitis. Our three Mayo Clinic campuses in Arizona, Florida, and Rochester are participating in these studies, and you might be a candidate to participate in them if you have granulomatosis with polyangiitis or microscopic polyangiitis. You may
Well, vasculitis, what it means. Vasculitides are defined by the presence of inflammatory leukocytes in vessel walls with reactive damage to mural structures, but loss of vessel integrity leading to bleeding and compromise of the lumen may result in downstream tissue ischemia and necrosis. Clinical manifestations. Inflammation in the upper airway is the most common initial symptom. There are some stages called localized vasculitis and systemic vasculitis. Arthralgia is more common than inflammatory arthritis that can be detected by clinical examination. Eye and orbital involvement is also striking in GBA, but in terms of frequency, 30 and 60% over time. The lung is affected in several ways. Pulmonary nodules, which are necrotizing and therefore frequently cavitate. Gastrointestinal ischemia of the duodenum and jejunum is a rare manifestation. This is a CT scan of nodules and the lungs, the nodules that cavitate. Current treatment regimens aims to reduce remission and then maintain remission using less toxic agents. Medications studied as remission maintenance agents include azathioprine, methotrexate, mycophenolate mofetil, leflunomide, trimethoprim, sulfamethoxazole, etanercept, and rituximab. The development of NCAP testing has facilitated the diagnosis and more localized and limited stage or with unusual presentations. GI complications are very uncommon, as I said.
Hi, I'm Mike Putman. I'm a rheumatologist at Northwestern, coming at you from ACR 2019. And I just got back from the ANCA-associated vasculitis guidelines talk, which was really excellent. And I wanted to share a couple of things that I learned there. So the first is that they're recommending rituximab over cyclophosphamide for induction of severe ANCA-associated vasculitis. I think a lot of us have been practicing that way, but I wasn't totally sure which direction the guidelines were going to go with that. The next couple things actually relate to the PEXAVAS study, which was a large randomized controlled trial of plasma exchange, but also had an arm for low-dose or normal-dose steroid regimen. And two interesting recommendations come from that study. The first is that they recommend against using plasma exchange for patients with severe ANCA-associated vasculitis. In the trial, it did not look like it was beneficial. There are some cases where I think many of us will still try it, but it's an important thing to know. The second is that they recommended a low-dose steroid regimen as opposed to a higher-dose steroid regimen. The actual protocol is available. I put it out on Twitter. Another important take-home from the guidelines is that they recommend against using ANCAs titers and B cells to dose rituximab. The main RITS-2 trial, which was published last year, had suggested that that was an option. In my opinion, it hadn't entirely excluded the possibility of an increased rate of flares just because of a power issue. And I have had trouble using this as a practical matter. I think it's hard to get rituximab restarted often if you stop giving it in a scheduled dosing regimen. And then the last thing is that they did recommend methotrexate for limited disease or for non-severe disease, which I think is appropriate. I have a number of patients who I've had success in doing this with. So great guidelines. I think it was a lot of work for the committee. If you'd like to learn more, please drop by the website at Room Now Live for all the reporting on this event. Thank you very much.
The cause. Death was primarily due to progressive failure of multiple organ systems. Patients continue to accumulate organ damage because of the chronic relapsing nature of these diseases. Renal involvement is common in GBA. In studies from the National Institute of Health in the United States, evident glomerulonephritis was present in only 18% of patients at presentation, but glomerulonephritis subsequently developed in 77 to 85% of patients, usually within the first 2 years of disease onset. This is a video about a rare presentation of granulomatosis with polyangiitis.
Hi, this is Dr. Artie Kavanagh. I'm here at RWCS 2016, and we're in the middle of the area where we have the fellows posters. And we have a very interesting, a lot of interesting presentations. We have one that's fellow Dr. Asfar from Wayne State is going to take us through and tell us about this. Looks like a very interesting case. Dr. Asfar?
Thank you so much for having me here. Trying to explain this case. So this is an 18-year-old female, totally healthy, that she presented to us with a 3-week history of sinusitis. She was treated with antibiotics by primary care, didn't resolve. Then she had eye proptosis. So bulging of the left eye. We did CAT scan, which showed the eye mass, if you can see here. This is the eye mass. All the cultures for infection were negative, so we did the autoimmune workup. She has ANCA positive and PRV positive. She really didn't have any respiratory symptoms, but we did x-rays, it was negative. She has little cough, so we said, let's go through this CAT scan. And we did the CAT scan, which showed like multiple cavitary and non-cavitary lesions, as you see here. And we did biopsy that, which shows the necrotizing vasculitis and granulomatosis. We did treat her with rituximab, 4 doses, the RAVE trial. And she really totally now asymptomatic. And we are following with her. We are doing the CD19, CD20, the C-ANCA, everything is undetectable. And we did a follow-up CAT scan of the eye and the lung. The lesions totally disappeared. So the lady is doing great. We're going to continue to follow up with her. Once we see any detection of the activity of CD19, CD20, or C-ANCA, we will give her another dose of rituximab. Thank you so much.
In Ecuador, there is no data of GPA, but some report cases, 2 in Guayaquil, 1 in Quito, and 1 in Ambato, some reported by Moreno of the Ecuadorian Society of Rheumatology with presentations of severe conjunctivitis, central nervous system, and renal involvement. The conclusions. Constitutional symptoms and inflammation in the upper and lower airway may develop simultaneously with systemic vasculitis or may precede it by weeks, months, or years. GI complications are very uncommon. For GPA, should cause rarely bowel ischemia with wall thickening of distal duodenum and jejunal loops. The treatment should consist in cyclophosphamide or rituximab and steroids initially. The goal is to maintain remission.
I'm Susan Davidson, and my daughter is Lauren Davidson. She's 12 years old. The sweetest child. I mean, I don't have any trouble with her at all. She's been a very healthy girl. She was a very athletic girl. She loves her dog. She loves her friends. And to see that transition in her when she was feeling so bad was very hard for me to see as a parent.
I have a disease called GPA. It's a really technical name. Granulomatosis with Polyangiitis. It affects your lungs and kidneys.
In October of 2015, when her swim coach sent me a text and she said, I had to make Lauren go to swim practice. I don't know what's wrong with her. She said she can't breathe and her coloring looks really strange. And it was about a week after her 11th birthday. She started complaining about joint pain.
GPA is hard to diagnose because of the non-specific symptoms. This is your immune system attacking organs in your body. A lot of people will look like they have an infection.
I would learn later she was having trouble breathing and her oxygen was low because the disease was starting to manifest in her lungs.
A lot of the medications we use for infection have some anti-inflammatory properties, meaning it'll decrease inflammation. So it looks like some people might be getting better, but they're in fact not getting better, and it's just putting a Band-Aid over underlying inflammation. Her shortness of breath, the fact that she couldn't breathe when she was doing her swim meets, made her come into the hospital.
They gave us 2 hospitals, and without hesitation, I said UVA. That's where I've grown up in Virginia, and I've only heard good things. I couldn't have been more pleased with all of the doctors. Everyone we encountered, she has seen rheumatologists, nephrologists, pulmonologists. Every one of them has just been fantastic.
Well, I had a doctor that I really liked. Her name was Dr. Charlton, and she was just very encouraging, and I really liked her because of her personality, kind of like mine. It was like really bouncy, just kind of fun, and so she kind of made me feel really better about the whole situation.
I don't even think that I saw Lauren initially. I told the ICU what labs to get, and within hours, those labs came back, and we had a pretty good idea of what she had. I see a lot of me in Lauren, and I think that's part of why we gravitated to each other.
Dr. Charlton has just been such a loving influence. She just cares for Lauren, and she told Lauren one time, she said, you have a tiger living inside of you. That tiger is either in its cage or it's out of its cage, and my job is to try to keep that tiger in the cage.
Her quality of life should be that of another girl her age. So for someone that was that sick and had to be poked and prodded so much, she did great.
UVA, that was an easy decision, and it turned out to be the best decision we ever made.
Thank you for your attention.